Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome. I'm Dr. Timothy Murray, Editor-in-Chief for JVRD, having you join us for our Authors Forum podcast. And it's a real pleasure as we highlight some of the key articles from JVRD to speak with Dr. Michael Klufas, who is from the Wills Eye Hospital, and put together an excellent original manuscript on outcomes of Rhegmatogenous retinal detachment repair in pseudophakic eyes with multifocal versus monofocal intraocular lenses. Michael, thanks for joining us first. Appreciate your being here.
Thanks for having me, Dr. Murray. It's a pleasure to be here.
So Dr. Klufas, we'll go there. That's been one of the issues that we've looked at with the onslaught of multifocal IOLs is that they have kind of shifted a little bit our approach to repair of retinal detachment. One, seeming to make the diagnosis maybe a little more difficult, seeming to make treatment a little bit more difficult. And your paper is going to suggest that maybe it impacts outcomes for these patients. So could you take us a little bit through the manuscript to understand how you put this together?
Yeah, great. Thanks for that excellent introduction. I think as vitreoretinal surgeons, retinal detachment is one of the most common surgical complications we manage. And now patients from our cataract colleagues are expecting many of these premium intraocular lenses. And, we pray for God for a toric lens. It's like a monofocal, but oftentimes we're stuck with some of these diffractive lenses with the rings, or even, in the past, we had things like crystal lenses with a small optic, silicone fogging under air, lots of different challenges. And that's just the technicality of the operation. Some of these patients are demanding a very good refractive outcome. And of course, as retina surgeons, we want to fix the retina. So, our impetus, I think, was there are many things that can affect the view during retinal detachment repair. And this was trying to isolate if some of these premium intraocular lenses, especially some of the diffractive ones, might influence our intraoperative view for things like shaving, identifying breaks, maybe how hot or cold the laser might be during the procedure, and if that might ultimately influence the outcome.
Well, it's interesting because I can remember vividly the first couple of cases that I did. One where the referring doctor said, "Don't you dare buckle this eye," because the patient was, plano with a $3,000 lens in their eye. And I pushed back at the time saying, we'll do whatever we need to do to fix the retina, because if we don't fix the retina, the refraction is not going to matter. Do you feel there's some pressure in these cases? And it was interesting that when you looked at your series, there was a significant successful increase in primary surgical repair rates with a buccal vitrectomy.
Yeah, it's a great point. Encircling band for sure, especially if it's low lying, may introduce a myopic shift. Sometimes it's not as much as we may think. I think it's always important for the surgeon to do what technique they're most comfortable with. You never want to put a surgeon in a position, well, someone's telling you to do this, someone's telling you to do that, and you're honestly the one steering the ship in the operating room. And as you said, we were trying to save this patient's vision. So I think you have to always do what's best in your hand. That's always one of the criticisms of these series with multiple surgeons. If someone's trying to tell you to do one thing or changing something intraoperatively, and if you want to place a buckle, you could even consider an inferior 180 tire or sponge or something if you're really, really worried about the refractive outcome. We didn't get into the weeds so much of that in our series. There are essentially some cases with encircling band, but much like many other series, the Pro Series and others, when you add an encircling band, often our single surgery anatomic success increases whether or not there's a myopic shift.
You showed at least a difference between the single surgical success rates overall, and showed that when you added buccal to either intraocular lens and did a vitrectomy, that was almost uniformly successful, correct?
Yeah, that's what we showed in the series. I mean, I think, the way I like to look at it is where we're talking about an individual surgeon's success. If you're not achieving around 80%, I think, or 85%, or even high 70s with primary vitrectomy, you might have to go back and look at your technique or be adding more buckles to your surgical armamentarium. But I do think, even in my hands, I love doing straight vitrectomy. It's a great procedure. It's great for the patient afterwards. But if there are features that may suggest I'll have a better anatomic outcome with a single surgery, then adding a low-lying band is something I'll definitely do. And just inform the patient preoperatively that there may be a myopic shift, or they may need glasses to have the best refractive outcome afterwards.
So, Dr. Klufas, the other thing that I thought was interesting was, and you've hit it a little bit, is that the surgical success rate for the multifocals for single surgery was around 76%. And for the monofocals had a surgical success rate that was was 10 points higher at 87%. That to me, that's a big difference.
I'm sure if we had a higher end, maybe more centers, maybe more surgeons, our results would have achieved significance. We were at, a little less than 0.05. So if we had set it at 0.1, it would have been, statistically significant. So I think it'd be great to investigate this topic further. There's certainly some limitations. We were just documenting if there was a multifocal intraocular lens, but there are so many different types in 2024. It's hard to glean what exact type just from clinical exam. You sometimes would have to go back to the referring doctor's operative report. So there are other things that we could control for if we tried to do a series or even a prospective series. But I think what it really comes down to is the view. If you're concerned about the view, or for that matter, if there's patient movement during the surgery and you need to pivot your surgical approach, I really think this study emphasizes that you need a good view to have good success with primary vitrectomy, to see the breaks, to remove the vitreous, not cause any iatrogenic complications, and deliver just the right amount of laser to just the right areas.
There's been some argument that, primary vitrectomy is your just, unbelievably effective pneumatic retinopexy, but I really don't believe that is all that we do. And you're suggesting that management of vitreous base and dealing with any tractional alterations and better visualization are key. So I think that's part of the clinical pearls that I felt you could take home from your manuscript. Is there anything else besides how important the view is that you think would be good for our audience to know?
Yeah, it's a great question. I think trying to assess the view a little bit preoperatively is also helpful. If you're able to see the break with a 28 diopter lens, I suggest that your view is probably going to be good under a wide angle viewing system. I've always been surprised with peeling in these cases. I think that's probably the worst view that we get. And sometimes you'll try the green lens with the ReSight system and you'll have a less distorted view. But people have even looked at things like triamcinolone particles, whether you're using triessence or off-label Kenalog, and they look different with these diffractive lenses. So, I think it can be a bird's eye view and then a microscopic view that can influence the surgery. And we sort of have to tease these things out. And perhaps things like some of the digital manipulation systems that we have now, Ingenuity, and others from Zeiss, these may have settings that may allow us to have a more optimal view during these types of surgeries. And then probably one other thing I would consider is if there is an issue with the view and you don't think you're getting all the breaks, you might consider being a little bit more generous with the laser, because we know missed breaks lead to redetachment and that can lower your success. And in my hands, I selectively use 360 laser. And if that's something I would perhaps consider in these cases, in our series, we did see a higher incidence of postoperative CME with the multifocal group, which was interesting. That might suggest that more laser was being administered because we're not seeing it quite as well, or not as white during the procedure, or other factors that influence surgical time and postoperative CME as well. So we got to kind of tease this out a little bit more.
You made so many key clinical points here. And one of those points, of course, is that the surgeon needs to guide their ship. And what you're good at is what you need to do. And you really emphasize that, whether that is you feel that you need a buccal with the vitrectomy, or you feel you need encircling laser with your vitrectomy, or whatever you need to be successful. But the other point you made that I love, that I don't think we talk about really at all, is look at your surgical success rates. And if your surgical success rates are not as good, in all honesty, as you think they should be, try to understand what do you need to bring to the OR to enhance that outcome. So I love talking with you. I think this is an incredibly pertinent paper, well written. These are very tough subjects to tease out because multiple surgeons and complex surgical procedures, but you did a wonderful job with your team of writing this. So Dr. Klufas, thank you for joining us from the Wills Eye Hospital.
Thank you so much. Thanks for having me.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD forum on the ASRS website to learn more. See you soon.